Hello, welcome to the Modern Management of the Older Adult Podcast. My name is Dr. Samantha Chamberlain. I am a TA within the Older Adult Division. We have two MMOA courses two live courses coming this weekend. One is in Paoli, Pennsylvania, and the other is in Baton Rouge. Cue the Garth Brooks songs. The next cohort of Essential Foundations is going to be starting April 26th, and the next Advanced Concepts is May 4th. Hi, everybody. Today, I want to discuss 3 areas that I highly recommend that you dive into and sharpen your skills on. This will likely turn into a multiple-part series as I further kind of digest and organize the information that I recently and am currently learning. So the 3 main areas that I'm going to kind of dive into, a little bit of a tangent in the beginning here just to give you some background. But the 3 main things that I want you to kind of take from this is check in on your vestibular assessments and how those can go far beyond a VOR. Check in on your visual screenings. As PTs, we can and should be going beyond saccades and smooth pursuits. I feel like that's kind of what we remember from school. And it's, if we're not treating in that kind of specialty area, that's kind of where we top out. And then your cervicogenic pathologies can be found with combination of visual vestibular and visual cervical screenings. So going beyond like the musculoskeletal and ligament laxity screens that we typically do for cervical, pathologies, and taking them into a little bit more higher level things that can be impacting some things post-concussion, or even like if they've had whiplash or a motor vehicle accident or things like that, or a fall. We are the older adult division. We do tend to understand that falls happen or tend to be more severe as we get older or have more injuries. So that's where this kind of comes in as far as the older adult topic. So this is going to be a little bit different dive into a topic than we usually do, because usually it's filled with expertise. But I want to kind of bring you into my novice experience as I develop my skills in this more concussion-based scenario. So some more background on how we got to this topic. Last fall, ICE had Dr. Jessica Swartz on the VICE, the weekly ICE meetup that is virtual. She is the founder of the Concussion Corner Academy, and the information she provided and the expertise that she brought in for that hour led me to take the full 12-week course. She has done a great job, just outstanding team she put together. It has people from physicians, clinicians, PTs, education specialists, ATCs. She has just brought the top people from the field regarding concussions and brought them in for this very well laid out course. This is not a formal endorsement, and we have no financial affiliations with Concussion Corner Academy. Anyway, the course has just been filled with a depth of information that is beyond what my expectations were. And it's definitely one of those situations that you don't know what you don't know. And then until you get in these situations. And then I've treated a few concussions with success, but I can only imagine how much quicker and how much better I could have treated them had I had the information that I have now. So now you're kind of up to speed on how we got to this point today. So if I say concussions, what do you think of? Most people are going to think athletes or sometimes motor vehicle accidents. But for the most part, you hear concussion, you instantly think like football or soccer, lacrosse, like some of those more higher intensity contact sports. However, as a clinician and a TA within the older adult division, I want us to also think of our older adults that tend to fall with less availability to kind of go into those protective movements. And during our courses, we discuss this study specifically. The title of it is Preliminary Investigation of Teaching Older Adults the Tuck and Roll Strategy. Can older adults learn to fall with reduced impact severity? The answer is yes, they can. So this study gathered healthy older adults, took them outside of their base support. They were on a tether, took them outside their base of support, and the tether released at random. No warning, just released. And so they got that baseline measurement of the impact at the hip and head acceleration. They did this again after training them how to fall, like that tuck and roll method, or, broader surfaces, roll with the fall type thing. Within the older adult division, we discuss this on how falls preparedness and practice reduces that impact of severity. But another perspective to think about on this is that baseline score that showed how much more acceleration of the head is present when someone hasn't had falls training, which in my mind would equate to a much greater risk of an older adult having a concussion as well. So not just a hip fracture in isolation, But I feel like that's usually what's focused on when we talk about falls with the older adults, or even when they go to the ER. I think that they typically are screening, make sure there's no hip fractures, things like that. But if there's no obvious sign of head impact, or if the patient says they didn't have head impact, I don't feel like that's being screened as well. And maybe they didn't have a true head impact, but they had a whiplash injury, which can also cause some brain tissue damage. So in this study, head acceleration, they saw a 54% reduction in head acceleration after training falls. Fall severity itself was 2 times less. Like there's an improvement of double in reducing severity of injury. So that's great news. And that's like a whole, practicing falls reduces injury by 50% is a whole nother topic. And we've hit on that before. But we as clinicians can make that big of a difference with just a few visits of training falls. So anecdotally, considering the study and thinking of if it was applied to our not so healthy patient population, because the study was done with healthy older adults. So thinking of more of what I see on the day-to-day, it's the not so healthy individuals. And what does that head acceleration look like for them at baseline without training, without practicing falls, without any of that? So whiplash and concussion, in my mind, suddenly become that much more likely, which leads me to that point today of simply doing some homework to up your skills. You're here listening to the podcast, so I know you want to be more than a mediocre clinician. You want to provide the best care you can to your patients. And sometimes that means digging in a little bit more, finding that good data, and being able to treat right what's going on. So some terms I want you to consider looking into if you're not familiar with them. Some of them we all know. You've made it this far in your career. You probably know them. But some of them are things that we might have glossed over and not really dug into. So accommodation, this is all kind of thinking about that visual system. We get 70% of our environment through our vision. So taking that into consideration alone creates like just mind blown when I heard that statistic or heard that fact. So accommodation, visual fusion, heterotrophia and heterophoria, vergence, near point of convergence, fixation, saccades, and smooth pursuits. Most people do the near point of convergence, but then they leave out vergence. So those are some things to kind of differentiate and look into. And then review ocular alignment. You can look up charts and it just shows like at rest, what's their ocular alignment look like? And then when you're doing these tests, do you have any variations from that normal view? And then going into the vestibular. So we have VOR. Most of us are pretty aware of that. Even if you're not well practiced in it, you can usually do some level of VOR, assessments. Fukuda's step test is another one that I've seen done, but one, didn't know the name of it, and two, wasn't using it as much as what I could have been or for this patient population specifically. BPPV, we're usually pretty good at screening. Balance, head thrust tests, smooth pursuit, neck torsion tests. This is one that was pretty new to me. I'd probably heard of it, but hadn't seen it applied or when to apply it. And if we haven't said it enough in this group, you have to go beyond static assessments and treatments. Gait alone is a far more complex motor task than static balance. So static tests are vestibulospinal. We need to assess vestibular ocular, especially with people that have had a concussion, such as walking with head turns. Sounds simple, but that's something that is very in line with what our day-to-day functions are like. We're not typically walking with our head straight. We're distracted, we turn, we do different things. We're taking in stuff visually as we walk. So that static test, again, is just not going to cut it for us. And then you want to consider your dynamic visual acuity, such as a Snellen chart with horizontal and vertical head turns. With that, those head turns are going to be to 30 degrees and to a beat of 120. So it's best if you have their head and you're turning them turning to the beat to that endpoint, because otherwise you're going to get either shortened or exaggerated, and you really want to try to stick with that 30-degree range and to that 120 beats. So start that metronome, use it, and have them read the lowest line they can on a Snellen chart. We can go into this, like I said, this could turn into a multiple part series where we kind of go through some of these less used tests and kind of hone in on what they're telling us and how to use them. But then I wanted to dive into the cervical spine screening and screening for cervicogenic involvement. So it takes 60 Gs to have trauma to the brain tissue, but it only takes 45 Gs to have trauma to the neck. So pretty much anytime you have any kind of rapid movement concussion as opposed to just a blow to the head, which even that can cause some level of neck tissue trauma, there's probably going to be a neck injury involvement if you have head trauma or brain injury. This is one of those and only always moment. Here is really diving into the symptomology and teasing out what's going on with this individual by doing a really good cervical spine assessment. So a cervical injury and a concussion share many of the same signs and symptoms. So let me give you that list. Headaches, dizziness, sleep disturbances, blurred vision, neck stiffness, balance impairments, depression, cognitive symptoms such as like brain fog or like just not feeling right. All of those can be concussion or cervical spine involvement. So you can see how it can start to be very difficult to say which is what. And if you delay one or the other, whether it's delaying focusing on brain recovery or delay focusing on neck recovery, because of course we want our brain to function properly. So you kind of triage that. If you can start combining those treatments after you do a really solid assessment, you are going to get that patient to a quicker recovery, which is so nice. And it's what they're all looking for. So we want to, of course, do our musculoskeletal assessment. We are experts in that, right? So ligament stability, range of motion, muscle palpation. You, of course, want to still do that for your cervical spine assessment. But then you want to go into some cervical spine sensory integration and proprioception testing. Because if there is a cervical spine proprioception impairment, then we are not getting the appropriate signals to the brain due to damage to the muscle spindles within the neck. So this can lead to those headaches, dizziness, and imbalances. If we're not getting that input correctly of like where our body is under our head, then we start feeling off balance. So you want to do a joint position error test. This is a laser on the head, have them look at a target, close their eyes, turn their head, and then back. So it's how close to that center of the bullseye they can get with their eyes closed with a head turn. So turn the head and then back to center with their eyes closed, open the eyes, readjust, do it again. You get 3 tries at this, each direction. So left, right, up, and down. And if it improves, then you can move on from there, and that the test becomes the treatment type situation. But that'll tell you how impaired that proprioception is with that person. You can also do the smooth pursuit neck torsion test that I mentioned with the vestibular screening. They kind of go in together. But that smooth pursuit neck torsion test, you have them turn their body, or you have them sit with their head turned towards you at a 45-degree angle and do a smooth pursuit test again with their head turned. So they're looking straight at you with their head at 45 degrees, and they're following that smooth pursuit. And then they can also do a swivel chair test. So you are, again, right in front of them, and then they are on a stool or a swivel chair, and they're turning side to side. Their body is turning underneath their neck instead of their head turning on top of their body. So all of those can give you so much more information. I actually used one of those today with a gentleman that he's an older adult. He's having quite a few symptoms, but he's only having symptoms when he's tilting his head back and turning. So definitely considering some cervicogenic involvement there. But he also has some vestibular, things that I probably typically before this course would have stopped at thinking it was BPPV or some other vestibular issue, and would not have been able to go into these screens like I am now. And it was very helpful. And he, felt heard and felt validated in some of his symptoms that he was having. So just some things to consider and add into your assessment from there. So just a quick review on what we talked about today. Like I said, this could go into multiple part series where we're kind of digging into each of those tests, what normal looks like, what abnormal looks like, and what the treatment afterwards looks like. But one, I highly recommend that course. But there's some other information that we can dive into here. So quick review, check in on your vestibular assessments, go beyond the VOR, add in some visual-vestibular components, consider dynamic visual acuity testing, and gait with head turns, as this mimics our real-life functional tasks. Check in on your visual screenings. As PTs, go beyond the saccades and smooth pursuits, okay? There's so much more that we can be doing there. And then cervicogenic pathologies can be found with a combination of visio-vestibular and visio-cervical screenings. Consider those smooth pursuit neck torsion tests that I just went into, and the swivel chair test, as well as the joint error position error testing. As always, thank you so much for listening, and I hope you all have a happy week of treating and happy aging to you all.